During the course of everyday practice, my colleagues and I have all too frequently encountered cases in which our feeling after initial scanning is, I've got it, I know exactly what's going on here, only to learn, much to our dismay, that I got it can mean a lot of different things. And yet it's precisely these types of cases that tend to be most instructive. So it's my hope that by sharing our misses and near misses with you, we can help prevent you from falling into the same traps. What we'll do is spend most of our time talking about the pitfalls of specific gynecologic masses, and we'll end by talking briefly about pitfalls related to the urinary tract and to endovaginal ultrasound. And we'll start by discussing the dermoid. Dermoids are common masses that frequently have very characteristic findings. For example, the finding of bright, linear, and intermixed punctate echogenicities within a mass that corresponds to hair is very characteristic, as we see in these two dermoids. Additionally, a complex mass that contains a highly echogenic focus that shadows, corresponding to a tooth, is another characteristic pattern of a dermoid. And finally, identification of a fat fluid level is also specific for a dermoid. However, it is the dermoid plug, a highly echogenic component of a mass that sometimes takes up only a small portion of the mass, but other times can constitute the entire volume of the visualized mass, that typically tips us off to the possibility of a dermoid. And here are some examples of a dermoid plug at transabdominal ultrasound and endovaginal ultrasound on the same patient. And you can see that the dermoid plug takes up a lot of the mass, but there is also a cystic component of the mass. Although the dermoid plug is what often tips us off to the presence of dermoids, unfortunately, it is also the etiology of most of the pitfalls related to over and under diagnosis of the dermoid. One of the main pitfalls, the most common, is that a dermoid plug can be mistaken for a loop of bowel. And if it's mistaken for a loop of bowel, the fact that there's a dermoid there may not be perceived as all. Here are some representative examples. This patient was referred with a palpable left adnexal mass, but on the initial transabdominal imaging, no mass was seen. Because of the history of a palpable left adnexal mass, additional scanning was performed, and with that additional scanning, you can see that there is actually an echogenic mass that attenuates sound located in the left adnexa. And in going back to the initial images, in retrospect, the mass was likely located here, but mistaken for bowel shadowing gas. In a similar example, patient referred with a palpable left adnexal mass, no mass seen on initial transabdominal imaging. Again, because of the presence of a palpable mass, additional scanning was subsequently performed, and it shows this echogenic rim with dropout of sound consistent with the dermoid, and this dermoid had an additional cystic component shown here. However, when you go back and look at the initial transabdominal scanning on this patient, the dermoid was nowhere to be found. Because it wasn't perceived, specific images of it had not been obtained. So in my experience, if an experienced examiner says there's a palpable pelvic mass and we do not identify the mass at ultrasound, usually the mass is present and we've missed the mass. And so we need to go back and look for the mass. And one of the most common scenarios in which this happens, that there is a mass and we don't see it at ultrasound, is in the presence of a dermoid, with the dermoid having been mistaken for a loop of bowel. And one thing that should be done is, if the imaging had been done with endovaginal ultrasound, transabdominal ultrasound should be performed, and vice versa. If the imaging had been done with transabdominal ultrasound, endovaginal ultrasound should be performed, because sometimes one of these ultrasound approaches will visualize the mass when the other approach will not. So here's an example in which transabdominal images of this patient with a palpable right adnexal mass did not visualize any mass. Therefore, endovaginal ultrasound was performed and shows an echogenic mass originating from the right ovary, and you can see beak of ovarian tissue coming around the mass, showing the mass is intraovarian. The other thing that should be done when there's a palpable pelvic mass and no mass is seen by ultrasound, is to re-examine all the echogenic areas that were previously thought to represent bowel, to see if one of these areas may perhaps represent an echogenic dermoid. Here's an example of how to do this. On this image, we have both echogenic bowel as well as an echogenic dermoid, so that you can see the differences within them. Here is the bowel. The bowel will elongate if one twists and turns on it, because after all it is a continuous structure, and the bowel will abruptly shadow, so that you won't see a lot of the leading edge of the bowel, as we see here, and often the shadowing will have a lot of artifact in it, so-called dirty shadowing, due to the shadowing being from air. On the other hand, here is the dermoid. And note that while there is a gradual attenuation of sound, it's much more gradual than with the loop of bowel. You can see much deeper into the dermoid mass, and you don't have the dirty shadowing that we had with the loop of bowel. Now, just as dermoid plugs can be mistaken for bowel, so can bowel be overcalled and mistaken for a dermoid. And this can happen both in the setting of a normal pelvis and normal bowel, as well as in the setting of bowel pathology. Here's an example of a patient who proved to be normal. We had what looked like a complex mass within the ovary with both a cystic component as well as a solid component shown here, which would be a good candidate for a dermoid. However, when additional scanning was done, this area began to peristalse, and therefore it could be confidently diagnosed as just representing bowel. This was normal bowel, with the cystic area that had been seen earlier simply being a prominent follicle in a normal ovary. How about abnormal bowel? Well, this was a case in which we felt rather confident that we had the diagnosis. This patient presented with right lower quadrant pain and had a highly echogenic focus in the right adnexal region. The echogenic focus seemed to be part of a larger mass, which was hypoechoic around the periphery of it. And the echogenic focus looked a lot like a dermoid plug, which is what we thought it was. And we thought we had really found the diagnosis then, when in addition to our dermoid plug candidate, we found a highly echogenic focus with posterior shadowing. That, we thought, might represent the calcification or the tooth within the dermoid. However, this proved not to be the case. The patient went to the operating room and turned out to have appendicitis. Now, how could this almost perfect example of a dermoid actually prove to be appendicitis? While the echogenic structure looked like it was a dermoid plug, in the setting of appendicitis, the mesentery and the omentum and the tissues around the inflamed appendix can become very inflamed as well and can be echogenic. And then explaining what looked like it could be a calcification or a tooth in a dermoid, that echogenic focus corresponds to an appendicolith. Finally, a uterine mass can also be perceived as a dermoid, particularly if the uterine mass is echogenic. And this can happen in the setting of a variety of fatty uterine masses, such as lipomas, myolipomas, or as in this example here, a lipoleiomyoma. Now, in this particular case, in which there's a highly echogenic mass in the uterus, one would not mistake the mass for a dermoid because it's clearly within the uterus. But just like fibroids can be exophytic and pedunculated, so can these fatty uterine masses. So in this example of an echogenic mass that was thought to be located in the cul-de-sac, the mass is seen here on longitudinal image and here on transverse image, and was thought to represent a dermoid, but turned out at surgery to be an exophytic lipoleiomyoma. Now, perhaps when one goes back, you can see that there was kind of an interface with the uterus that might have retrospectively suggested the possibility this mass could have been arising from the uterus, but nevertheless, that was not perceived at the time of the study when the diagnosis was not known.